Well, good evening, everyone. I'm glad that you folks found time to make it tonight. And my name is Raman Muthusamy. I'm Medical Director of Endoscopy for UCLA Health. And I'm going to be talking about Transoral Incisionless Fundoplication, or TIF. Have we finally found an endoscopic treatment for GERD? These are my disclosures. And in tonight's talk, I'm going to sort of cover several areas. First, I want to briefly cover why have prior endoscopic anti-reflux devices failed, and in 2020 that we, still don't have an established device until what I believe is now. We'll then talk about the TIF procedure. We'll then cover indications for the procedure, how to work up patients that are being considered for the procedure, and then discuss the post-TIF care. And then finally, I'll conclude with the evidence summary. After describing it, we'll look at the evidence that's there, and which is quite substantial. And then we'll conclude, and I'll have some time for questions. It talks about 40 minutes. We should have about 20 minutes for questions. So let's start with prior endoscopic anti-reflux devices, and we'll go for a little background, which really starts with the anatomy. So you've got the esophagus. Obviously, you have the stomach here in blue in the fundus. You have the lower esophageal sphincter muscle, the squamous-columnar junction, or Z-line, typically, the diaphragm across here, and again, you've got the gastroesophageal flap valve sort of down here, which really maintains the closure of the stomach by the pressure in the stomach to prevent reflux. And it's a breakdown in this anatomy that really leads to the development of GERD, and it's usually at multiple locations. So in the blue here, the frontoesophageal membranes deteriorate in their elasticity, and so the GE junction doesn't sort of return into the abdominal cavity after a swallow. The angle of His, which is important, this angle right here, sort of goes from being an acute angle to sort of an obtuse angle. The hiatal hernia, of course, is when, again, the lower esophageal sphincter changes its alignment from being at the level of the diaphragm to above it. So here it's at the level, and here it moves above. And then transient lower esophageal sphincter relaxation. So all of these play a role. And again, you can see sort of that there should be some amount of intra-abdominal esophagus here. You tend to sort of see motion above here and a loss of this angle of His, which I was talking about. And this is a sort of prime setup for the development of reflux. And it's important for us to understand this anatomy. I think part of the reason the early efforts failed was they didn't really take what we had learned from our surgical colleagues into practice. And so it was not surprising then that we didn't have great results. So again, surgical therapy for GERD began in 1911 with Mayo, who repaired a hiatal hernia. Nissen performed the first successful anti-reflux surgery in '56. And then in the 1990s, a laparoscopic version of Nissen's procedure came about and was popularized. And so there was a massive increase, essentially a five-fold increase in fundoplications performed in the 90s, from about 20,000 to over 100,000. And while early data suggested that it was 90% effective with 5-year follow-up, this was subsequently questioned in a JAMA paper in 2001, which I'll get to in a minute. So again, the fundoplication takes the fundus and essentially wraps it around, brings the esophagus down and wraps it around sort of the lower esophagus, as you see here, and it's a 360-degree sort of wrap. Again, there's some cost to it. It requires, obviously, it's a surgery, and depending upon time, it may not be 4 hours now, but it does require some time, usually a short hospitalization traditionally, and then some period of time for convalescence. And while acute perioperative complications were rare, chronic postoperative complaints, particularly dysphagia and glass bloat, occurred in a significant portion of the patients, and in fact still continue to do so. You can see somewhere between a quarter to maybe even half of patients may have some of these symptoms. So I'll go back to that VA study, which looked at 247 patients who had this Nissen fundoplication done, and they had about a 10.6-year follow-up for those who had just a control group of medical patients versus 9.1 years follow-up for surgical patients. And they had follow-up in about 129 of these people. Now, it should be noted there was a limited number in the surgical arm. But the main point that got sort of all the press at the time was that 62% of people in the surgical treatment group still were on medications at the end of the follow-up period. So the feeling was, you went through all this, but at the end of the day, you were there's a good chance you'd be back on medical therapy. Now, a subsequent randomized controlled trial looking directly at PPI versus surgery found that surgery was better, but the main point is that the surgical procedure still had about a 33% failure rate in terms of requiring medications at the end of follow-up. And again, this was better than the original study, but still a sizable fraction. So the question becomes, if you are someone who maybe doesn't want a surgery for a variety of reasons, possibly due to just not wanting a procedure versus not wanting to do something that may require you to be back on medicines, and you don't want to be on medicines long-term. Certainly some people it's just hard to be compliant. Other people are concerned about side effects or medication interactions. Would there be a role for a third option? And is there a need for one? And so, again, it's always been sort of the question. I'm sure this woman's husband probably wishes that there wasn't a third option, certainly not the lipstick option in his case. But really, that's been the debate. Do we really need a third option, given the fact that we now have medicines that work pretty well, and we have surgical therapies that actually have gotten better over time as well? What would be the role, and how would we do it? And so in the early 2000s, this was very hot. And there were thermal techniques that, the Stretta procedure, which I'll get to, that limited reflux by collagen deposition around the cardia. Stretta is the Italian word for tighten. There was concepts of suturing and stapling methods that could alter the angle of His or elongate the LES. And that actually more represented what our surgical colleagues did. And then there was sort of a thought that let's just plump it up. We'll just inject something into the wall of the LES to bulk it up and see if that would help increase the tone to sort of help with that. So I was reminiscing about this quote with Jeff Conklin in the hallway yesterday. This is sort of a timeless classic here by Walt Hogan in Wisconsin, that the millennium ushered a array of paraendoscopic devices and procedures designed to prevent GE reflux. Similar to a holiday turkey, the esophagus was stuffed, stitched, and baked by enthusiastic endoscopists intent upon preventing gastric reflux and eliminating the need for antiacid medication. And so we eagerly embarked on a variety of studies looking at this. I was involved in actually one of the first endoscopic sham trials. It was a randomized sham trial of the radiofrequency energy technique, or Stretta, which I mentioned earlier, which essentially put electrodes into the lower esophagus, into the muscle, trying to induce sort of some level of fibrosis and collagen deposition formation, which would then tighten the LES. There were other devices. This looks like a fancy bicycle pump, but this is actually an endoscopic sort of suturing device. It's meant to cinch. This failed primarily because it really didn't put the stitches in deep enough. It was really mucosal. Same issue with this other device that never really saw the market. Now this device here, this endioplicator, really is very similar to what kind of a precursor to the TIF procedure that we're going to talk about today. And then, as I mentioned, there was some idea of bulking up the GEJ, as you can see in the photos here, by doing various implants. And one was a liquid implant that sort of became polymerized. Unfortunately, if you inject sort of at the 7 o'clock position here, the aorta is right behind that. And unfortunately, in some cases, this was injected directly into the aorta, and there were significant renal complications from renal emboli. The Medtronic gatekeeper never came out. So despite the fact that several of these devices gained FDA approval, Enterix was approved in 2003, was removed from the market in 2006. Endioplicator has undergone essentially variations have occurred, and sort of TIF sort of takes that concept now today. Stretta has been around, but hasn't really caught a foothold, and EndoSitch failed because, as I mentioned, it didn't get deep enough. So as we evaluate therapies for endoscopic anti-reflux devices, we really should look at a variety of factors. First, does it help in healing damaged tissue? Does it prevent complications long-term from developing from reflux? Is it safe, and what are the side effects? Is it convenient both for the patient and the doctor? What's the cost, and how does that cost compare to the alternatives, medical therapy? What is the durability, and what is the reversibility? And The cost issue is a lot different now than it was 20 years ago. 20 years ago, I was a GI fellow, and at that time, when I was at the VA, you couldn't start, primary care physicians could not start a PPI. They had to be sent to GI clinic, and we'd have to assess if there were candidates for a PPI because we were trying to control the cost. Now it's over the counter, of course, so times have changed. But at that time, the cost equation was expensive medication long-term versus a surgery that might require expensive medication. So this was very hot at the time, and all of these devices came to market. Now, I can give you a quick summary of the results. It's kind of like this magician who unfortunately didn't do the trick right and had to have a split casket. None of these really worked because, again, I don't really think the understanding of the anatomy was sufficient. We really didn't correct it as it should have. And so there was sort of a dark period. Certainly, I was rather cool to these technologies because I felt like I had already sort of hit the ground once and I wasn't going to jump on, particularly because I didn't think that the devices that were there were in the right space. Which kind of leads me to where we're at now, which is the TIF procedure and the body of evidence and how it differs. So I'm going to now transition to the TIF procedure, which again stands for Transoral Incisionless Fundoplication, and which is the name of the procedure. Now, the device that you use to do the procedure is called the Esophageal device. And that's this sort of white-handled device here, which the tube goes through. And actually, the endoscope comes in one end and comes out the other. And you look with the endoscope, but you actually do the procedure with this device. And this is what the fundoplication with the device looks like afterwards. So the idea behind this device is it's got several parts. It has some suction here in the esophageal part, which kind of helps grab the mucosa and pull it down to help reduce small hernias. It's got a mucosal grasper here, which allows you to grab the mucosa, pull it in, and then you can use this device to sort of perform the wrap. And then it's sort of secured by these fasteners, these Serosifix fasteners here. And that's how you do this. And we'll go over how many fasteners and so forth. So the original procedure was called an endoluminal fundoplication. At that time, it wasn't getting very high up, as I'll show you in some pictures. It was really a gastrogastric plication with only 10 fasteners. And so the connection was done below the Z-line. It was modified to become the TIF 1.0 procedure, which was the year of FDA approval. And at that point, it went about 1 centimeter above the Z-line and now had 12 fasteners. And then it really underwent a more significant revision where up to 23 fasteners were placed with more proximal placement, really now shooting for at least 1 and up to 3 centimeters above the Z-line. And really, it's this latter procedure that's been performed since 2009, now well over 20,000 times. And the device, the Esophageal device, has been modified many times. There was an Esophageal Z that came out in 2016, and the most recent version is the Z Plus, which came out in November 2017. So again, here's the evolution of the procedure, and over time, as you can see, sort of the level of the wrap has increased. So the TIF 2.0 is about a 270 wrap compared to a 360 Nissen. So essentially, we've increased the amount of intra-abdominal esophagus and increase the percent of the wrap. And again, this just shows you the timeline, the number of cases done. 96% of commercial cases have been done with the 2.0 technique, which I just described. And it's really the only one of the three that really attempts to provide a wrap. So the effect of that, of course, is the more you wrap, the greater the high pressure zone. So you can see this is what a normal high pressure zone in the esophagus G-junction area looks like. In reflux, it's obviously attenuated. You've got some increase in pressure with endoluminal plication, and then the TIF 1.0, and you see that you're starting to get higher and higher levels of pressure, approximating in this and not quite with the TIF 2.0 procedure. And when you compare the sort of the modern 2.0 procedure to fundoplication, again, this procedure can reduce hernias that are 2 centimeters or less, but not more than that. And if the hernia is larger than that, it will require a concomitant hernia reduction surgery with crural closure. It does help elongate the intra-abdominal esophagus. and it can help approximate and tighten the fundus around the distal esophagus, as I mentioned, really a 270 wrap, and attempts to recreate the dynamics of the angle of His and restore that high pressure zone that I just mentioned. So again, we're trying to more surgically approximate than some of the other procedures. So here's a patient that has probably, you know, that's probably a Hill grade, almost a 3 there, I would say. So this is probably a little bit large. Usually though, with the hernia reduction, probably would be needed with this, and then subsequent TIF, you can see that you've increased that intra-abdominal esophagus and really sort of restored that tissue angle here. And you can see the level of thickness between the esophagus and the stomach. You can see there it's about 34 millimeters on that CT image. So I'm going to show you a schematic here. This is just a video that kind of describes what the heck it is we're doing. So
the esophagus technology is designed to rebuild.
Let me take the audio off of this. This is a 60 French device. It's 20 millimeters. So we'll talk about contraindications, but you need to make sure there's no esophageal stenosis. And so what you're going to do is essentially pass the endoscope through the esophagus device and then lead with the endoscope. So it's almost like an overtube kind of thing. You've passed this down. These patients are usually intubated. And then once you go down, you pull the scope back, and then there's actually a side hole you can come out, and then you can use the scope to help visualize and then perform the procedure. So you need 2 people to do it. One person holds the scope, one uses the device. And again, you can use the tissue grasper here, and then you sort of bring it in and then close. And then this is how you create, you know, sort of your plications. And this again is a gastroesophageal plication. And the idea is you're trying to create, you know, a significant amount of intra-abdominal esophagus here. So you can see that you do this. And then you have these 2 serosal fasteners here that are deployed. So with each one, and this has been automated in the most recent version, so you can do this relatively quickly. So once you've approximated this, then you release, and then you keep going around as you sort of do this until you do the 270. When you finish, you end up with approximately, you know, 20, 23, potentially even more, depending on what you want to do. And you get this omega-shaped valve. So this is a bit like a toupee. And then the idea is that with serosa to serosa, that you're going to get serosa fixation here, which will sort of make this more durable, which is why in the early days, we don't want a lot of solid food. We don't want big chunky things here that will stretch or put tension on this. And we certainly don't want emesis. So antiemetics are very important. But this is what the valve will hopefully look like when you're done with the procedure. And it's done with under insufflation, so you get a good sense of the tension that's there. And so hopefully you'll get a very good approximation here. But this is what it looks like when it's completed. Okay. So now that we have some idea of what it is that we're doing and some of the anatomical corrections that it does, let's talk about indications, workup, and post-TIF care. So again, this has traditionally been done in those age greater than 18 who have partial to incomplete response with daily GERD symptoms that are typically present for at least a year while they've been on PPI period for over 6 months. So this is really for PPI partial responders, you know, who you know, we know that it's reflux, but it's not completely responding with PPI. They tend to have, you need to really have a Hill grade 1 to 2 flap valve. I'll come back to that in a minute. And of course, you have to have evidence of GERD either by esophagitis on endoscopy, a positive pH study, or radiographic evidence of reflux on some kind of barium imaging study. Again, the hernia needs to be less than 2 centimeters in size. And again, people who are on a PPI who have a proven abnormal pH or endoscopy findings also would be candidates, of course, as well. So the contraindications really are, again, I mentioned the Hill valve and the big hernias, BMIs above 35. And then most of these are sort of the standard bleeding disorders, severe esophagitis, and anything that would potentially cause esophageal strictures or stenosis because of the size of the device is 20 millimeters. So it really requires a non-constricted esophagus. So any obstruction, neck mobility will make it difficult to have the device enter, osteophytes, etc. And so that's really the big contraindication. Now, probably the most important thing for referring physicians to do is to sort of assess this Hill grade. And the reason I mention that is because if the Hill grade is 1 to 2 and the hernia is less than 2 centimeters, those patients can be done directly under endoscopy without the need for a hernia reduction or being done in the operating room. They can be done in the endo suite. So, but it's very important to get that right, because if you really try to do one of these cases here on the bottom right, you're not going to be successful without sort of repairing the hernia, tightening the crura. So it's critical. And sometimes getting a single picture isn't enough. You really need to sort of park yourself for about 30 seconds, ride the air, bring the tissue up closely, bring the scope in tight to really see if there's some laxity. So here's a normal ridge. This is nice and snug to the scope. That's a 1. Slightly lax. The ridge is slightly well defined here, and someone opens with respiration, that'd be a 2. These two are okay for a straight endoscopic procedure. Now you see this is clearly not hugging the scope, and sometimes you may only get this view after a few seconds or maybe intermittent, but this is a 3, and then these are obvious big hernias where the hernia is wide open at all times. You can see that the GE junction is moved up quite proximally, and these clearly, as you can see up to top, are going to require some surgical assistance as well. So again, when you're doing your endoscopy, we traditionally are taught to measure the axial, hernia, where we sort of look at where the diaphragmatic pinch is and where the edge of the gastric folds are and see if they're normal, or if the diaphragmatic pinch is at one level and the end of the gastric folds at another level, and say, okay, that's a 2 centimeter axial. But you also want to look at the transverse sort of hernia aspect here. And here you can kind of see that based on the number of scope widths here. So here you can see there's probably 3 scope widths here. Scope's about 9 millimeters. It's probably a 3 centimeter sort of transverse hernia. And so this is definitely something, again, that would not be a candidate for a direct TIF. It would really need a surgical correction of that hernia. So how do you pick who you might want to consider this to or bring it up to in the office? We obviously know GERD is super common. Fortunately, most patients between lifestyle modifications or medical therapy are able to get satisfactory relief. But there will be a group of people, probably 10 to 20% at least, that may have suboptimal response or intolerance to the PPIs, or may simply not want to be on it for other medical reasons. And these are the people that can undergo further investigation, typically with some form of pH testing, manometric testing, and again, the endoscopy with hernia and Hill classification, as I just mentioned. And in those patients who are Hill 2 or Hill 3 with reducibility, those middle of the road patients are ideal candidates for this. And as long as they don't have one of these contraindications that we kind of discussed earlier, discussion of TIF may be appropriate, particularly if there's appropriate motility and so forth. But again, you have to confirm that there is reflux and make sure they're an appropriate candidate with regards to the hernia size. For those with very large hernias, I think it probably just makes sense if it's not reducible to just do a straight operative candidate. So these are really for those low, moderate to kind of early severe sort of reflux patients that you may be able to ideally find an opportunity for. The procedure is typically done with general anesthesia, on average about 45 minutes. Experts may be able to do it in as little as 30. I think people just beginning about maybe more an hour. It requires 2 operators, as I mentioned. There's some thought that potentially intraop paralysis or some elevation in PEEP may help avoid diaphragmatic injury during plication, although that's not a mandatory thing. And prophylactic antibiotics as well are often given, as well as fluids and antiemetics intraprocedurally, because we want to avoid people from vomiting right after having this done to avoid too much tension or trauma to the plications. And patients are usually admitted overnight for observation. Upon discharge, we certainly want to control any pain, so analgesics, antiemetics to control nausea, vomiting. We don't want a lot of burping either, so anti-gas agents to relieve bloating and discomfort. Laxatives, again, to avoid any kind of bloating and discomfort there, and avoid constipation and straining. And again, some patients, it's probably best to bridge them with some PPIs until, they're fully healed from their surgery, or from their procedure, excuse me. So in terms of diet, I mentioned you don't want to have a very heavy diet in terms of solid foods. You really want to try to keep a clear liquid diet for about 3 days. You then move to sort of a more of a full liquid blenderized sort of diet after 3 days until 2 weeks. Weeks 3 and 4, you can move up to pureed foods and then medium soft foods for weeks 5 and 6. And then usually after 6 weeks, you're able to sort of resume sort of a more regular diet. So the company does have some information. I want to credit my partner, Darsh Thacker and Nancy Jaffe in our division, one of our dietitians, who really put together a beautiful document. I'm just showing you a couple of pages here. This is a 15-page document, which gets very granular for each stage of this diet in terms of what foods to avoid, what are some general tips. And then here is, for example, adding in pureed foods, what that looks like. And you can see specific items. It tells you even what you can snack on. So really a terrific thing. And so this will really help, I think, patients avoid confusion and concern about what they can and can't do during that month-and-a-half period. So in addition to diet during that 6-week period, again, activity, again, you want to start with sort of light activities, minimal physical activities, slowly increasing it in terms of week 2, but still no intense exercise. And then you can start lifting light weights during weeks 3 to 6, and then again, after 6 weeks, you kind of resume normal activities. Typically, patients are seen 1 to 2 weeks after the procedure, often then at 3 months, and then after that, as needed. Some study patients are followed out to 6 or even 9 months. There's a variety of resources that are available for patients, including instructions, there's post-op orders, and even very detailed instructions on how to set up the room for the procedure. And so, it's been pretty well worked out now with over 20,000 cases. What about insurance coverage? Can medical insurance cover this? And there is a Category 1 CPT code for this procedure. There's one for it being done alone in conjunction with the hernia repair as well, and there's the codes there. The hybrid TIF procedure is really covered by all parties, both commercial and Medicare. And each operator, both the person doing the TIF and the person doing the surgical hernia repair, is essentially paid at 60%. The straight TIF procedure, which doesn't involve surgery, it's all endoscopic and can be done potentially in the endoscopy unit, is covered by Medicare and select private payers, but many private payers will require prior authorization. Here's a map which kind of shows how many people are covered lives there are for sort of a straight procedure. You can see the majority are made up of Medicare and Medicaid. There are commercial payers, certainly, that cover it, although not really in the California area. Really, some patients in Nevada who come here may be covered, but the rest will require authorization. Okay, so we've described the procedure, a little bit about the post-procedure care. Now, let's talk about the data, and let's look at the evidence summary. And so for this, I would recommend 2 articles that are fairly recent. There's a nice summary in gastrointestinal endoscopy by some docs at Harvard and Mayo describing more specifically the TIF procedure. And this is available online. It'll be out in gastro soon. Mike Vasey, Nick Shaheen, and I wrote a state of the evidence for all anti-reflux devices, including surgical. It's 22 pages, so it's quite detailed. I'm going to give you the Cliff Notes version of this for TIF, which is the section I wrote. And the reason I actually am giving this talk and decided to get involved is because after reviewing the evidence and after sitting out for about 15 years, I really did finally feel that we had benchmarks met that justified its use more broadly. So there are 5 systematic reviews of this device. There are 5 randomized controlled devices, 2 compared to sham, 2 with PPIs, and 1 compared to Nissen fundoplication. Multiple cohort studies, 140 publications at least, with over 1,600 unique study patients. And there's up to 8 and 10-year now longitudinal follow-up. Now, the TIF data, of course, like any procedure that's evolved over time, there's some, as I told you, not a ton of data on ELF and the TIF1 because most of the cases are 2.0. And then, there's some variability in how many sort of fasteners are put in. There's also some variability in trial enrollment and heterogeneous patient populations, as well as exactly which parameters were measured, which quality of life measures were measured, which GERD scores were measured, and how things were considered positive or negative, which you'll see with some of the data. But in summary, at a high level, what can you tell your patients? Pretty universally, patients are improved symptomatically with statistical significance improvements in heartburn, regurgitation, and GERD-related quality of life scores compared to sham procedures. Acid reflux is objectively reduced in the majority of these studies, statistically significant, and even normalized in a significant fraction of the patients, in some cases, the majority of the patients. And that's something we never really saw with any of the devices in the early 2000s. The impact on LES pressures is not as well studied, but there is some data, again, showing that it significantly can improve the LES pressures, but that's not a measurement that was made as routinely in a lot of these trials. And the need for PPI therapy is reduced at 5 years. 40 to 90% of people were able to stop PPI at various stages of follow-up. And importantly, unlike what you would get typically with medications, because TIF is actually trying to restore the barrier, it is superior to PPI in eliminating or reducing regurgitation and extraesophageal symptoms. So there are a lot of systematic reviews, as I mentioned. One was a meta-analysis of 32 TIF studies, of which 22 were with the TIF 2.0 protocol, 1,200 patients, which again showed that it's technically pretty easy to do, 99% procedural success. Adverse event rate was 2%. And again, there's a temporal variation in this, which I'll get to. Significant improvement, again, seen in GERD, hearth-related quality of life, and pH scores. The hernias reduction was achieved in 91%, and the PPI use was eliminated in 7 out of 8. A second analysis compared only randomized trial that either used LAP, Nissen, or TIF, and had a comparison with either sham or PPI. And with 7 studies with 1,128 patients. And it found that TIF was actually the best improvement with health-related quality of life out of those. It was better than Nissen. However, Nissen was better with objective parameters such as LES pressure and acid exposure. So these are just sort of graphical. This is meant to be high level. So you can see on average, when you talk about GERD-related health quality of life, most of these studies had people starting in the mid to high 20s, some in the low 30s, one as high as 46, and they dropped down usually into the mid single digits. So you can see a pretty substantial reduction in each of these groups. Overall, the improvement was about 80% from baseline. And if you need to remember one number, in general, it tends to improve most of these things around 80%. So if you look at specifically studies focused on TIF 2.0, again, you see a whole bunch of different numbers here, but on average, it was about 81% across 11 studies with 568 in terms of getting people off their daily PPI. And if you take a look at, hey, do you heal esophagitis? We said that was one of the criteria, or at least improve it by 1 grade. And again, this is where different studies will use different endpoints, but you can see about 80% of the time that they were able to achieve those endpoints. So what about TIF and pH reduction? Let's move to more objective measures. And so this looked at 6 different studies looking at either Demeester score, pH study, or number of reflux episodes. And you can see that it was statistically significant improvement in all 3. It normalized in one study. In 2 other studies, it was elevated but improved. But a significant fraction of people in these groups actually normalized their pH. And this study, interestingly, I think highlights what we're learning. This is actually the most recent study, that when you can completely get the anatomy right, that means maybe perhaps doing a hernia reduction when needed. I think maybe that wasn't done as rigorously earlier on. 95% of patients with intact anatomy were able to normalize their pH studies. So patient selection is everything. But I think if you do it right, you can get very good results. Now, what about safety? The serious adverse event rates cumulatively is 2 to 2.4% in the largest meta-analysis, but it should be noted that half of those nearly occurred with the 1.0 procedure. And this appears to be decreasing with time, as I'll show you, likely due to increased experience and, again, refinements in that esophagus devices, and there have been several revisions. most recently in 17. Most common serious adverse events, as I mentioned, are perforation, bleeding, and pneumothorax, all under 1%. And there were no perforations in any of the 5 randomized trials of the TIF 2.0. Minor symptoms include chest or abdominal pain, nausea, bloating, and shoulder pain. I had to sort of painstakingly review the MAUDE database from the FDA for 7 years for all TIF-related adverse events. I found about 4 per year. And most commonly, these were lacerations, perforation from device insertion, some chest-related issues, effusions, pneumothorax, abscess, and rare GI bleeding. So here's the numerical numbers here. And if you take a look here commercially of 25,000 cases, there's been about 99 reported sort of serious adverse events. So that cumulative rate now really kind of drops to a very low number, because this is, you know, the systematic review was including a lot of the early TIF 1.0s. But you can see here, this is about 1/6 of what was reported in that systematic review. So durability, this is always the bugaboo for a lot of these devices. We just talked about that in the beginning with even Nissen fundoplication. We're starting to get a limited subset of patients who have got, you know, long-term data. This study was from Europe, had a few patients, 14 that had 10-year follow-up, and about 92% had either stopped or have their anti-secretory use. So it's a little bit nebulous how many had stopped, how many had halved. This is a study with 8-year data that looked at 57 patients, of whom 23 had long-term follow-up. And here they found the majority had at least some level of daily anti-secretory use, medication use, but 80% were satisfied overall with the management of their GERD and having undergone the procedure. So we still have some areas future study. I think we better need to define which patients ideally we'll work on, probably define and stratify patients' response based on how good you know, the anatomy was restored, what procedure factors may be associated with efficacy and durability. Of course, a randomized prospective trial comparing to TIF to surgical fundoplication would be welcome, but will be challenging and will take time. Assessing anatomic limits of the technique, you know, could you do some Hill grade 3s under certain conditions, or maybe slightly larger hernia sizes? And if so, what refinements in technique would you need? Would you need a larger wrap? Would you need to use more fasteners to potentially help with durability? So these are things that still need to be worked out. Here's sort of a general TIF versus surgery, and you can see that it's fairly comparable in terms of the efficacy numbers, not maybe quite as good in terms of normalized pH, but perhaps the main advantages are in terms of the rates of significant adverse events, and also in terms of postoperative complications such as dysphagia and gas bloat, which are probably one of the benefits of using a 270 wrap as opposed to a 360 wrap. So again, this was my little cheat sheet for evaluating therapies. Let's come back to it. And I think as we close, I think we've shown you data on evidence in healing esophagitis. Preventing complications is a little harder to do because you have to, but again, if you do heal the esophagitis, we believe that's a precursor to most of this. I've shown you what I think is a fairly reasonable safety profile and also a fairly efficient procedure. Again, we covered the cost. It actually is reimbursed. It's typically a short observation. The durability of the procedure, I believe, is, again, it's always the challenge, and we need more data. But as we start having a larger number of patients undergo this, I think we're going to get a better idea and better predictors of durability. And again, the procedure, if it fails, you can do an anti-reflux surgical procedure. You can do a Nissen afterwards. And conversely, you can also do this procedure after a failed Nissen. So where does this follow? Similar to obesity procedures, out of the potential number of people who would fall in the category that would be appropriate, only a tiny fraction are electing to do so. So out of 6.7 million potential patients, only 30,000 or so, less than 30, elect surgery. And it's probably in part because the medications are generally effective, but more and more people are worried about the medications for a variety of reasons. And so people in this sort of moderate reflux symptoms, probably 30 to 35%, maybe even borderline on the low end of the severe scale, might be candidates for this. I still think, obviously, the most severe should go to conventional surgery. And again, I think we're finding that we need to do a greater number of these potentially as hybrid cases where that we're very rigorous about correcting the hernia and the crural defect. So there's limited data on using this device in people who'd already have a Nissen. This series of 10 patients who they did, they get most of them off therapy, and 5 out of 6 were actually able to normalize their pH studies. So in concluding, TIF appears to be a safe, effective, and relatively durable technique, more data, that improves the symptoms, reduces PPI use, and often certainly improves and often normalizes objective parameters such as pH. We need to really select patients carefully, which I've emphasized multiple times today, in terms of assessing the Hill grade in the hernia, and I think that's essential to achieving success. And again, it doesn't preclude subsequent fundoplication and may even be used after failed prior fundoplication, as redo fundoplications can be very challenging. So in 20 years, I was doing a lot of work in the early 2000s with this. Chang was in the lab at that time, which was at that time state of the art. Of course, things are very different, and was one of our technicians. And Ken was kind enough 20 years later to actually come. He's actually been a pioneer of TIF as well, and he helped us do some of our first cases here at UCLA. So this is our team, including my partners, Ollie Sederat and Darsh Thacker. On the surgical side, Joe Hines, Dave Chen, and Ian McQueen. Again, our interventional group, 5 people and excellent partners. And who knows if this expands, we may have more of our colleagues doing this as well. And of course, we want to bring technology to our newly named Robert G.KARDASHIAN Center for Esophageal Health. This is the opening event. And we feel that this is an important addition. So with that, I'll stop and I'll take any questions. Thank you for your attention. And I think we can open it up to questions.